Hello, everyone. Good morning, good afternoon, good evening, and early good morning to Zach, who's going to be presenting the case today. And we are having Dr. Restrepo today with us, and he's going to be discussing the subspecialty case. And if you have been here long enough, you would know that he's our favorite. And Dr. Restrepo, would you like to introduce yourself and say a few words? I'm sure everyone knows you, but did you want to just say hi and did you want to say some few words?
Hi, everybody. It is 7 p.m. in Boston, Massachusetts, which is where I live. I am Dan Restrepo. I am a general internist and hospitalist at Massachusetts General Hospital here in Boston. I'm one of the associate program directors for the residency and also one of the associate editors of the case records of the Mass General, which is also known as the New England Journal of Medicine, CPCs. And so I love all things diagnosis and clinical reasoning. And I don't know why I keep on doing these because everybody gives me really hard, mean cases. And I asked that explicitly that this be an easy, nice, down the middle case in order for me to come back. But I don't think that wish was actually honored.
Nope, it wasn't. Maybe next time, Dr. Restrepo. And so, Zach, did you want to say hi?
You're muted,
He
Zach.
couldn't.
Hi everyone, I'm Zach. Yeah, it's currently 1 a.m. here in Cape Town, but only a case as exciting as this would keep me up. Excited to present this very rich and amazing case.
And this is not going to be possible without Sam scribing as well as Saket doing the teaching point. And we do have one small question for you, Dr. Restrepo. In case I turned on your Apple or Spotify or your audio, what is the playlist? Either a song or a podcast episode or an audiobook which is playing?
I have been listening to one of my favorite pianists. His name is Ben Folds. He's a singer-songwriter and an amazing piano player, and he just released a concert live with the National Symphony Orchestra here in Washington, D.C. in the U.S. And so it's all of his like songs that have spanned his portfolio over time, but with a world-class orchestra behind him, and it's pretty cool.
Oh, that's awesome. Do you go to orchestras often? A symphony?
I'm afraid I'm not cultured enough to go to the orchestra often, but I like to go to music concerts though.
Oh, that's beautiful. And I think summer's around the corner. It's actually summer. And then, yeah. If I turned on mine, I'm actually listening to the audiobook by Zarna Garg, and she's a stand-up comedian, and she's released a recent book called One in Billion, I believe. And then it's so funny. It's hilarious. And then like I'm just rolling with laughter, like, and then getting sunburned. um, Zach, if I turned on your playlist, what's playing?
EM Crit probably.
Okay, that's fun. And are you ready, Dr. Restrepo, to solve the amazing case we've prepped for you today?
Like I said last time, I'm not. I don't think I'm ready, but I'm prepared.
Okay, awesome. Sam, whenever you're ready, can you share the whiteboard, please?
Okay, so let's get started. So the case I'm presenting, I'm going to be presenting it in 6 aliquots, and then the 7th will reveal the final diagnosis. Huge credit to Dr. Jeffrey Shen over from Duke Rheumatology for sharing this wonderful case with me. And he titled it in the old age famous saying in medicine that it's not lupus, it's never lupus. So I'll go ahead with the first aliquot, and that's that of a 59-year-old woman with a history of Sjogren's disease who was recently started on hydroxychloroquine, presents with sudden onset of vision loss. So just a timeline of events 3 weeks ago, on the phone with her sister, which she does sometimes when she takes walks, and her sister noticed that she was breathing a lot harder than usual. And then initially she thought it was nothing, but then she noticed some mild wheezing And she says that it felt similar to previous episodes of her asthma exacerbations that she experienced earlier in life. 2 weeks prior to presentation, she saw a PCP who gave a treatment for what was diagnosed as an asthma exacerbation, which included a short 5-day course of prednisone taper and azithromycin for 3 days. And she also noticed that sometimes she has a mild non-productive cough as well. And then 3 days prior to presentation, she noticed some blood-stained sputum in her cough. And then also she noticed that she dropped a fork, and when she went to pick it up at the time, she hit her head. And later on, she developed a headache, which she accredited to the bumping of her head, or to one of her migraines, which she said she gets from time to time. Although she did note that she was more dizzy than previous migraines, and then she experienced this sudden onset of blurry vision during the episode. So some review of systems, some pertinent positives. She was nauseous. She also endorsed non-bloody diarrhea, a non-productive cough, mild pleuritic chest pain, shortness of breath, fatigue, arthralgia, myalgia, and generalized weakness. She also had some night sweats, and she said that her eyes have been sort of dry. Also endorsed myalgia, and she discussed that her pain was in her shoulders, arms, and thighs, and that this improved when she was on that short course of prednisone for the asthma exacerbation. Some pertinent negatives: she denied any fevers or chills, denied unintentional weight loss, no new rash, no Raynaud's, no dry mouth, no pain with eye movement, and no eye redness. And I'll stop there for the first aliquot.
Wow. Okay. So there's a lot there. We've learned a little bit about the patient in terms of the enabling conditions that may set us up for kind of low-hanging fruit in the differential diagnosis, and always important to think about kind of as gets thrown around here, background and foreground. But we hear of a woman with autoimmune disease characterized largely by Sjogren's syndrome, for which she is on hydroxychloroquine. We hear about antecedents of asthma. We hear about antecedents of migraine, at least. And we see her presenting with sort of a litany of different symptoms that span multiple different organ systems. We hear about sort of some hemoptysis and dyspnea on exertion. We hear about wheezing sort of in the cardiopulmonary bucket. We hear about neurologic symptoms such as headache, which may or may not be post-traumatic or maybe migrainous. So those things definitely are kind of pinging around in my head. We also hear a single medication exposure thus far with hydroxychloroquine, which is known to cause sort of retinopathy and vision loss, although this is sort of a cumulative effect and not shouldn't be sudden in onset as this is. And so those are kind of a few interesting points as we're thinking about them. You know, as far as large buckets, obviously when somebody has autoimmune disease, we need to think about sort of either manifestations of the autoimmune disease that she already has, of which the extraglandular manifestations of Sjogren's are myriad, including sort of a secondary vasculitis, or we need to think about a sort of unrelated, but I guess posse-related autoimmune disease, such as a secondary vasculitis or a secondary connective tissue disorder. We'll hear a little bit more about any other immunomodulators or immunosuppressants that's on. We heard a little bit about prednisone and maybe some prednisone responsive symptoms, but obviously need to think about in these folks that are chronically immunosuppressed, atypical infection manifesting in a multi-system way. And then obviously great to always get a chance to talk about small, medium, and large vessel vasculitis in this case, which can present with constitutional symptoms, the hemoptysis and pulmonary symptoms, as well as the antecedent quote unquote asthma. Always makes me think about eGPA, but obviously GPA with the kind of cranial symptoms. Again, small vessel ANCA associated vasculitis can cause a lot of cranial symptoms. But also, you know, she is now above 50, which puts her in the range of GCA, especially with the kind of vision loss, the classically sort of painless monocular vision loss, but also GCA with multiple kind of cranial vessel symptoms as well. So that's kind of what's bumping around my head. I'm going to need a little bit more information in terms of what medications she is on, social histories, any other kind of immunosuppressants that would really alter the scales on that. And obviously, I think it was said here before, it's not lupus, but certainly, you could definitely get a secondary lupus or a lupus Sjogren's overlap. All of these things are very fair game. It'd be really mean if you titled the case "This is not lupus" and it ends up being lupus. But I think for in the interest of completeness sake, and then had you mentioned that the shoulders and the hips were involved in terms of the myalgias and arthralgias?
Yeah, so she said the myalgias were it was shoulders, arms, and thighs. So yeah, hips.
Shoulders, arms, thighs. And then how much prednisone was she on?
Unclear how much, but I
And
presume
do
the
you know if
standard
she
dose for
felt
the
better?
exacerbation.
No, that's okay. Do you know if she felt better instantly? Like somebody said the word prednisone to her and she got better?
I don't think so.
Okay. So whenever you hear, especially low dose prednisone with an immediate response, an immediate therapeutic response, sort of that kind of PMR, GCA spectrum needs to kind of come in because those folks feel like they came back from the dead the minute you say the word prednisone to them. So that'd be a useful tidbit to have there. But we don't have to jump on that more. I think we're gonna need a little bit more information and an exam, and she's gonna need some chest imaging with the hemoptysis. I'm gonna want to eventually, obviously examine her, look for signs of mononeuritis, look for signs of any other neurologic involvement. Not that I'm good at the ophthalmic exam, but I'm sure that would be really rich if somebody actually took a look with a fundoscope, a full neurologic exam, full skin exam, and a good cardiopulmonary exam as well.
Dr. Restrepo, and would you still go around trying to find out more history or do something about start the management? Is that something which you would do about the vision loss as of now? Or
I
would you
mean, I
wait to
guess I
know
would probably
more?
clarify: is this just blurry vision, or is she frankly like has binocular or monocular vision loss? Because I think if we do have sort of true vision loss, and it's that acute, then she needs to be emergently evaluated. If it's lots of people have blurry vision, the most common cause of it is just dry eyes, which Sjogren's predisposes her to. Shouldn't be acute, but certainly lots of systemic conditions like hypo or hypoglycemia or hypertension, hypotension. There's a litany of things that can cause blurry vision. I think if we get a little bit more information on it, or as long as she's not having like emergent vision loss, especially like kind of curtain drop or eye pain or anything like that, to suggest optic neuritis or some sort of very serious craniomotor process or space occupant lesion, then I think that we can get a little bit more history.
Thanks for that, Dr. Restrepo.
Okay, fantastic discussion thus far. So, second aliquot, some past medical history. So she has a past medical history of Sjogren's disease. She said she had issues with watery eyes for the past 2 to 3 years and was diagnosed with dry eyes. Then 9 months ago, her ophthalmologist ordered some lab tests, and that lab test showed a positive ANA. And she was then subsequently sent to a rheumatologist who diagnosed her with Sjogren's a month ago. And at that time, hydroxychloroquine was started. She also has long-standing hypothyroidism, long-standing hypertension, long-standing migraines, and she describes it as sort of a headache between her eyebrows or behind the eyes, which is associated with nausea and dizziness. No clear preceding aura before that. She also has a history of asthma, which she was diagnosed as a child, and it's unclear whether she ever had lung function tests previously, but this is being managed by a PCP. She has very occasional exacerbations, and it's usually when she's around her friends who smoke cigarettes or when she has a cold. Other past history and medication. So for medication, she's on hydroxychloroquine, she's on lisinopril, hydralazine, somatroptan, celecoxib, and then just some eye drops, levothyroxine. Then past family history, her mom has hypothyroidism. Social history, she doesn't smoke, drink alcohol, or use any illicit drugs. Surgical history, she had a hysterectomy many years ago for fibroids. And I'll stop there.
Okay, good stuff. So we hear that the asthma is diagnosed in childhood. I'd want to know a little bit more if she actually had other atopy or allergic rhinitis. If it has truly been her whole life, it makes it less likely. But I always question sort of the diagnosis of non-atopic asthma in folks that are, in adulthood. Like new onset asthma in adulthood should always make you think about a misdiagnosis in that case, especially if there's not an antecedent longstanding atopic asthma history. Things like congestive heart failure, things like, EGPA, which we've already talked about, eosinophilic granulomatosis polyangiitis, vocal cord dysfunction, lots of other kind of asthma mimics that arise late in life. Certainly want to think about them. If it truly has been like her whole life, that makes it maybe a little bit more of noise and not signal. But again, always get a good sense of what the asthma duration is, and are there any other atopic features or atopy in the family. We hear some meds. Obviously, Plaquenil or the hydroxychloroquine can cause, again, the ophthalmic and the retinal manifestations of it. It seems, again, 1 month of it doesn't seem to be super likely, but definitely something that needs to be evaluated for, and she'll need a dilated eye exam. Whenever you hear hydralazine, it is one of my absolute least favorite medications on the planet. It doesn't work that well, and at least it's toxic. That's what I always say about hydralazine. You have to dose it a bunch of times a day. It has unpredictable pharmacokinetics, especially when given IV, but especially when discussing these kinds of cases, drug-induced lupus, which I get is not lupus, but also ANCA-associated vasculitis, a mixed sort of MPO and PR3 vasculitis has been attributed to hydralazine. So definitely going to be looking for signs of small vessel vasculitis, especially can have alveolar hemorrhage, it can have pulmonary manifestations, it can have pretty much any manifestations at once. So definitely drug-induced lupus and ANCA-associated vasculitis have pinged around in my head, especially with some of the antecedent symptoms that were described. I'd want to know, it doesn't sound like a very convincing Sjogren's story, so it makes me wonder if that diagnosis was falsely attributed to just a positive ANA. I would say that not all ANAs are created equal, and if her titer was 1 to 40 or 1 to 80, anywhere from 25% to 10% of the population will have a positive ANA at that titer. And so titer matters. I'm not smart enough. I know that Dr. Miloslavsky was on here this week, who's a good friend of mine and mentor. So he's taught me most of the rheumatology that I know, but I'm not smart enough to remember the patterns, but I do know that titer matters. So I'm going to want to know the titer, and I'm going to want to know if any other extractable nuclear antigens were available that are perhaps more specific to Sjogren's, SSA, SSB, also known as Roux and Law. And then we can talk about further testing a little bit further down the road, but I'm going to want to know those things kind of going right off the bat. NSAIDs, she's on celecoxib. Another thing that you always want to try to really blame quickly because they have myriad kind of pleiotropic effects in the body and can cause a lot of atopic symptoms. It can cause eosinophilia. They can cause drug-induced vasculitis. And so another thing that kind of caught my eye. But I think that's where I'll pause and I'll talk about kind of what my wish list is in a little bit.
Zach, did you want to give him his wish list?
Sure. So let's go ahead with the physical exam. Vitals temperature was 102.6, heart rate 118, blood pressure 128/78. She was saturating at 84% on room air. HENT, her eyes were without redness, no oral or nasal ulcers. She had decreased vision, which was blurrier centrally in the central vision as opposed to peripheral. She had palpable, mildly enlarged, soft, non-tender cervical and axillary lymph nodes bilaterally. Cardiac exam, she was tachycardiac without any murmurs, gallops, or rubs. Pulmonary exam, she had diffuse fine crackles throughout. Dermatological, she had no rashes, no telangiectasias, no calcinosis, no sclerodactyly. MSK, she had synovitis of the left more than the right wrists. Neuroexam, normal sensation in tone, muscle strength 5/5 throughout, symmetric, normal reflexes, and cranial nerves were normal. Some initial labs that were obtained early on showed a white cell count of 7 with no lymphopenia, hemoglobin of 9 with a hematocrit of 29 with an MCV of 94, an LDH of 520, and a haptoglobin that was undetectable. A basic metabolic panel was obtained and it showed a sodium of 135, a potassium of 3.7, a chloride of 103, BUN of 56, creat of 2.4, and a glucose of 104. She had an AST of 73, an ALT of 92, and an ALK-Phos of 190. Her albumin was 2.2 with a protein of 7.5. Her CK was 156. The TSH was 4.0, which was within normal limits, and a T4 was 0.65, which was lower than the normal limit. A UA was obtained, which showed 1+ protein and 1+ blood. And I'll stop there.
Okay. Interesting. So may I ask, before I dive too much into this, was it heme positive urine with cells, or was there actual hematuria, or like, was it just heme positive urine, or was there actual red cells in the urine?
We sent it off for microscopy later on.
Oh, we send it off for microscopy later on. Okay, great. Okay, there's a lot here. So to the exam, she has a fever. We've established that really beyond the hydroxychloroquine, which is immunomodulating, she is not overtly immunosuppressed by her medications, and kind of going through her medical history, it doesn't seem like something is screaming as a very immunocompromising standpoint. And so she's sick, but she's not crashing, which means that we can get some data. And while fevers should make us prioritize infections just by the fact that they kill people quickly, I do think that autoimmune inflammatory disease is very much in play, and there are several kind of factors that are making me think that, and obviously sort of malignancy as well. The tachycardia is probably just the fact that she is febrile, but I think with hypoxemia as well, we need to consider venous thromboembolic disease, alveolar hemorrhage, or lots of other things that we're going to have to investigate with imaging, which we'll get to in a second in terms of the imaging. As far as the laboratory data, pretty convincing sort of panel, at least in the hemogram, for a hemolytic anemia with an undetectable haptoglobin, as well as an elevated LDH. So hemolysis can be intracellular, extracellular, or it can be immune or non-immune. So that's kind of how I think about hemolysis mostly. As far as the immune and non-immune part, I think that the next step that we're going to have to take to investigate the cause of this anemia and the hemolytic anemia would be a Coombs test, as well as a smear, but we'll get back to that in a second. As far as the intravascular and extravascular, that's partly why I'm asking what the microscopy shows. So if you have heme positive urine without any cells in the presence of hemolysis, that would suggest intravascular hemolysis, as opposed to like extravascular hemolysis that you see with lupus or certain drugs, which tends to be extravascular, and it's less likely to have sort of free heme in the urine from intravascular hemolysis. Looking at her liver chemistries, certainly she has a decent globulin gap, which could just be indicative of inflammation, but also raises the possibility of viral infections, such as chronic viral infections, such as HIV, hepatitis B, hepatitis C, or paraprotein mediated disease. So certainly with AKI and the anemia and all these other things, we'll probably have to think about that in a second. And the last thing in the labs to really discuss is that she has acute kidney injury with blood and protein in her urine. So this is kind of don't pass go glomerulonephritis until proven otherwise, in my mind. Certainly free hemoglobin and hemolytic anemias can result in AKI. Certainly, there's lots of other things that can do that, but that's the first thing that really pinged in my head. Again, you're starting to see a lot of different manifestations. We have pulmonary, renal, hematologic manifestations, suggesting a multi-system disease. Lupus, drug-induced lupus, obviously can both manifest with hemolysis and glomerulonephritis and AKI, as well as alveolar hemorrhage, VTE, pulmonary vasculitis, lots of other things in the chest as well. So I am sorry, despite that this is not lupus, it's never lupus. I think we have to talk about it because it can certainly check a lot of these. She also has arthritis, which can be seen with either any vasculitis, but also with SLE. In terms of the kind of other sort of as far as like an inflammatory arthritis like RA, this seems like a lot of sort of extra articular manifestations to say that this is RA. So I'm still probably going to be landing in the connective tissue disease bucket or in the vasculitis buckets in terms of the different kind of rheumatologic diseases. And you'll notice I'm staying away from the visual stuff because it's probably the thing that I'm least comfortable with. I'm actually not entirely fully sure kind of how to entirely think about this central visual field deficits. Or cranial blurs are normal, or neurologic exam is normal. I think I would probably, in my case, being as bad as I am with a fundoscope, call my ophthalmology colleagues, especially in somebody that's on hydroxychloroquine, to take a look at her. But I think that lots of things need to be obtained. I would certainly obviously start with an electrocardiogram and a chest radiograph, but she's, in my mind, going to need probably a CT pulmonary angiogram to discard VTE and to get a better look at her parenchyma in terms of worrying about things like organizing pneumonia or alveolar hemorrhage or other kind of sterile causes of hypoxemia and tachycardia, as well as just regular bacterial pneumonia and sepsis. I'd want some blood cultures as well. And then I really, really want to see what's in the microscopy. Zach, can I ask for my fancier things now, or are those wait and see?
Dr. Restrepo, I have one question for you. By having a cervical lymphadenopathy, how are you prioritizing vasculitis? Isn't it something that is like if you find lymphadenopathy in the neck, it isn't vasculitis? At least that's how I remember it from.
That's a great question. I was sort of trying to manage like what to do with this lymphadenopathy. I don't know that I fully. I mean, sort of systemic inflammatory disorders can certainly cause that. I obviously was it. You said it was tender or non-tender?
It was tender.
Okay, so acute.
Sorry, it was
obviously she has
Apologies.
non-tender.
It was non-tender.
No. I think certainly with the lymphadenopathy, unexpected finding. I don't think it discards any of the other kind of diagnoses that I was hinting at. Maybe start to prioritize lymphoma as something that can cause multi-system inflammation. If it's truly, and it's lymphadenopathy, not like cervical, salivary gland enhancement or enlargement.
It's cervical. It says cervical lymphadenopathy, not salivary.
Oh, okay. So because the salivary gland enlargement can obviously be seen if you truly had Sjogren's disease or, funkier diseases like IgG4 related disease. There's no adenopathy anywhere else, at least on exam.
Yeah, so it's cervical and axillary.
Oh, axillary. Okay. Sorry, I didn't hear the axillary part. So then that would qualify as generalized adenopathy, which again, chronic inflammatory conditions can certainly do that, but we do, I think, need to think a little bit about lymphoproliferative disorders if that's the case, and then like the really weird like Castlemans of the world and all these other things that are discussed in CPCs and in places like this. But IgG4 related disease, I think we will get a little bit of epi. This woman was in Raleigh-Durham. She's from Raleigh-Durham. In terms of TB risk factors would be the other thing, or other endemic mycoses.
Okay, fantastic. Yeah, no, you
Does she have
any
sort of TB risk factors or anything like that?
Unclear, but the patient was seen in the United States, so I don't think so. Probably low risk.
And no sore throat or anything like that to suggest
No.
Okay.
Okay, so the patient was admitted for further workup. Patient was started on empiric high-dose steroids for potential GCA. Rheumatology and hem-onc were consulted early on. Some further labs that were obtained, an ESR of 86, a CRP of 25, A blood smear was positive for schistocytes. Direct Coombs was negative. Some ID workup was positive for rhinovirus, but negative for HIV, Hep A, B, C, EBV PCR, CMV PCR, Parvo B19, all negative. Serologies for Lyme, Mycoplasma, Rocky Mount spotted fever, FTA antibodies for syphilis, blastomyces, quantiferon TB gold, syphilis, histoplasma, urinary antigen were all negative. A TTE was negative as well. In terms of the room workup, she had a positive ANA with a titer of 1:2,560, positive SSA, positive SSB, positive IgG4H at 866. She had a ferritin of 866. And then pertinent negatives, negative for double-stranded DNA, Smith, RNP, SCL70, histone, JO1, C3, C4 levels were normal, rheumatoid factor was normal, negative CCP, negative lupus anticoagulant, negative anticardiolipin, anti-beta-2 glycoprotein, RNA polymerase 3 negative, ANCA negative, MPO negative, PR3 negative. In terms of a heme-onc workup, SPEP showed polyclonal hypergammaglobulinemia, and then free light chain ratio was within normal limits, and IL-6 levels were undetectably high. And I'll stop there for the fourth aliquot.
I gotta tell you, I don't know what to do with an L6. All right, so there is a lot of negative data here. So her ANA is convincingly positive in this case, that she at least had a backdrop of a connective tissue disease. Her hemolysis is well categorized as being non-immune hemolysis, and with the schistocytes, I'd worry about a thrombotic microangiopathy in those cases. What were her platelets? Remind me.
She had a thrombocytopenia at 122,000.
122. Okay, not like crazy low. Not like usually like TMAs are pretty low, but certainly she has anemia, thrombocytopenia, schistocytes, and she's Coombs negative with hemolysis, which does suggest a thrombotic microangiopathy. The things that cause thrombotic microangiopathies would be something like DIC, where was her INR, her PT, and her PTT normal? Did we talk about her coags?
I believe they're within normal limits.
Okay, so that just makes DIC unlikely. We talk about malignant hypertension. We talk about scleroderma renal crisis. Again, all of her scleroderma testing is negative, and she didn't have anything on exam that suggested it. Then we can get to like the quote unquote autoimmune thrombotic microangiopathies, of which lupus is certainly one of them, and can present with sort of all of these findings. And then we think about other things like TTP, HUS, right? She has fever, she has neurologic symptoms, she has not crazy renal function. So classically, TTP actually doesn't cause profound AKI. That's more HUS and atypical HUS. Certainly she has, again, she's checking a lot of boxes. What doesn't, and she has schistocytes, what doesn't fully kind of line up with that is that her platelet count isn't super duper low. But maybe you're going to tell me that if it drops and it goes down to 5, then certainly I think TTP has to be prioritized. There's the plasmic score, which is a quick way of prioritizing what is going to be, whether or not the Adams TS13 is going to be positive or not. But because many institutions, it takes a long time to come back. I don't know what her plasmic score is. I bet you it's probably decently high, probably doesn't get a lot of points for that, but certainly would want to actually check an Adams TS13 level. She has extensive, do we ever have the eye exam?
Coming up in the next aliquot.
Oh, in the next aliquot. Okay, great. I'm sorry, I'm just gonna look through all the other stuff that I wanted to chat about. Yeah, in general, I think that this puts us in a tough spot. I think we're probably, unless you show me something very revealing in the eye exam, which I don't know much about eye exams, where this is the point in a case where I'm thinking about tissue, Certainly like getting a tissue diagnosis at this point, given that all of the non-invasive diagnostics have come up a little bit equivocal. I think in cases like this, obviously the quickest thing to access would be an axillary lymph node. But also, with their degree of AKI, depending on kind of how it went clinically, a renal biopsy would be another place to go in these cases. So those are most of my thoughts. The only other interesting thing is sort of the disconnect between her ESR and her CRP. I know you're telling me that this is not lupus, but classically patients with lupus actually do not produce large amounts of CRP within a flare. And that large splay between ESR and CRP can sometimes suggest SLE, even in the midst of a flare. What doesn't argue for a flare here is that her complements are normal, but I think it's still kicking around in my mind.
I have two questions for you, Dr. Restrepo. How are you processing the ferritin levels? And the other one is like you were
The
mentioning the
SBET.
drug-induced. It could be, and then with all the labs so far and the physical examination, are we still concerned about it could be a drug-induced or a complication of any of the medications? Or
I mean, I think the answer is yes, right? It could still be drug-induced vasculitis. Beware of diagnosis by serology. So it certainly still could be hydrol-induced drug-induced lupus. It could still be, an ANCA-associated vasculitis. When there's renal involvement, um, uh, that classically the ANCA is taught as sort of like greater than 90% sensitive. I have seen seronegative ANCA vasculitis even with renal involvement. So I'm, again, kind of keeping this in the back of my head. As far as the microscopy, I really would be interested in hearing about it and seeing whether or not there were dysmorphic reds, or if you're super duper lucky, red cell casts, which will definitely put you in the GN sort of bucket. So those are kind of the things that I'm kicking around. The ferritin just means she's inflamed. I don't know that it's not like HLH high, but I haven't heard about organomegaly or confusion, but technically she does have fever and pancytopenia and adenopathy, but it's pretty paltry. I don't know what her H score would be, but I don't think it would be super high. So things that I would still want, depending on what I'm hearing, is probably tissue. The microscopy, we haven't gotten like really good look at her lungs. At least I haven't heard about cross-sectional imaging of the chest and the belly to look for more nodes or spleen being big or lymph nodes being big. And then I'm thinking about an excisional biopsy at this point, and then wanting to look into her eyes.
thank you so much for that.
You asked and we shall provide. So the urine microscopy showed a urine PCR ratio of 2.2, and it showed granular casts without white blood cells or red blood cell casts, consistent with acute tubular necrosis. The ophthalm exam, a fundoscopic exam was performed, and it showed macular edema, cotton wool spots, retinal hemorrhages, and flecken consistent with Purcher-like retinopathy in the bilateral eyes. In terms of some imaging, she got a CT chest, which showed bilateral ground glass opacities and patchy consolidations with peribronchovascular thickening. It also showed bulky mediastinal and hilar lymphadenopathy and small to moderate bilateral pleural effusions. She got a CT of the abdomen and pelvis as well, which showed bulky abdominal lymphadenopathy and mild hepatosplenomegaly. In terms of an FNA was done of the mediastinal lymph nodes and a BAL as well. And that essentially the FNA showed fragments of biopsy with non-specific features of inflammation, no evidence of atypical or large lymphocytes on limited exam. And also showed some lymph nodes are completely effaced by inflammatory infiltrates, mostly plasma cells. And the conclusion was that findings are non-specific and can be seen in a variety of infectious, autoimmune, and lymphoproliferative disorders. And the stains of those were negative for infectious causes, such as viruses, bacteria, acid-fast bacilli, fungi. And then, acid-fast bacilli culture and fungal culture showed no growth. And then in terms of the BAL, it was negative on a viral panel, negative for a bacterial panel, negative for acid-fast bacilli and fungal counters as well. And it was negative and negative studies for cytology and flow. And I'll stop there with the fifth aliquot.
Zach, did they have a they didn't see blood on the BAL? Serial lavage wasn't like further blooding?
I don't believe so.
Okay. All right. So we have generalized adenopathy or organomegaly with maybe some sort of inflammatory and necrotizing debris. But this is why you get tissue. And so we're thinking about things that are sort of causing generalized adenopathy with a host of multisystem manifestations. We're thinking about sort of lymphoproliferative disease in this case. We're thinking about sarcoidosis. Whenever you're talking about these things, obviously is going to come into play, maybe too late in the discussion, since all of the serological testing is negative, and part of diagnosing sarcoid is figuring out that it's not something else. Then we think about weird things, the multicentric Castleman disease and IgG4 related disease and all these other. You said her IgG4 was elevated?
It was indeed elevated.
Okay. So this seems, and then she had no peripheral eosinophilia, right? On the differential.
Yeah.
Okay. All right. So certainly IgG4 related disease can cause organomegaly, multisystem involvement. It can cause post-renal AKI by retroperitoneal fibrosis. It can cause lots of different things. Typically it's men, and typically it's men in their sort of 70s to 80s that get it, but I guess stranger things can happen. So that's certainly one thing that we're talking about. I don't think we've discounted cancer at this point in time, lymphoma specifically, but also sarcoidosis. I do think we're going to need an excisional biopsy of one of those lymph nodes. I think, if you can palpate it on axillary exam, that usually means that it's size worthy to go for it. Or the alternative would be to get like a PET scan or something and look for alternative targets. The scars up here are less sort of appetizing than over here, but also depending on which is the biggest of the lymph nodes, then that would be one to go for targeting in terms of anything that would be appetizing to look at under the microscope. As far as her renal studies, it makes glomerulonephritis less likely. It doesn't make thrombotic microangiopathy associated AKI unlikely. So that can certainly be happening, again, post-renal AKI from IgG4 related disease, even without signs of hydro on the imaging can also do this. Intravascular hemolysis doesn't seem to be the case about what's going on here. So those are my thoughts. I think we need tissue, unless there's something that I haven't touched on in this case thus far.
No, I think you covered pretty much everything. And Zach, would you want to go to the next aliquot?
Sure. So we got an axillary lymph node biopsy, excisional biopsy was obtained, and it showed marked sheet-like interfollicular plasmacytosis, along with increased vascularity and follicular dendritic cell prominence. And the comments were that findings are non-specific and can be seen in a variety of infectious, autoimmune, and lymphoproliferative disorders. And then stains were negative for infective causes such as viruses, such as HIV, HSV, EBV, HHV8, bacteria, acid-fast bacilli, fungi. And then plasma cells and lymphocytes are polyclonal. And then there's no kappa or lambda restriction. And then there was increased IgG4 cells, but the ratio of IgG4 to IgG cells is much lower than the 40%, and an aberrant T cell population was absent. And then I did mention this earlier, that the acid-fast bacilli culture and fungal culture showed no growth, and flow cytometry showed an absence of a monoclonal B cell population. A bone marrow biopsy was also performed, which showed mildly hypercellular marrow and increased presence of dysmorphic megakaryocytes with hyperplasia of megakaryocytes and mild signs of myelofibrosis and no signs of HLH. And then it also showed moderate polyclonal plasmacytosis that was present and no evidence of kappa or lambda restriction of cells. And then, like I said earlier, the flow cytometry showed no evidence of clonal B or T cell or plasma cell population. And lastly, a renal biopsy was obtained, and that showed glomerular microthrombi in a pattern consistent with TMA, and immunofluorescence was negative for immune complex deposition of immunoglobulins or complements. And I'll stop there, and the next aliquot will reveal the final diagnosis.
I mean, looks like her immune system is just very revved up in a non-specific way. And I don't have anything much more intelligent to say there, except that it doesn't appear to be a typical infection of the reticuloendothelial system, like all the ones that you've told me it's not. It doesn't seem to be a clonal lymphoproliferative process. Again, it doesn't probably, it's not probably HHV-8 associated Castleman disease. It may or may not still be within the specter of IgG4 related disease, or she could just have kind of global immune activation. It doesn't seem to be HLH. I'm actually not fully, I'm going to be fully transparent. This is like three orders of magnitude beyond my pay grade, except for the fact that she has a TMA. And that we've already been talking about the kind of the different causes of it. Obviously, we discussed the plasmic score being probably, if we did the math, somewhere in the send the plasma, think about TTP in her. I don't. It's an extraordinarily rare disease, and so this degree of sort of reticuloendothelial activation, all these other things, probably exceeds what I know about it. To be honest, in the cases that I've seen, atypical HUS tends to present with more AKI, but I guess it's atypical for a reason, and so need to think about that. But we didn't hear. We did hear about a diarrheal illness at the beginning of all of this, and so I guess certainly it is possible. But I am honestly grasping at straws because you guys have given me an incredibly mean case in this hour that we've been together. I guess, is there anything other else that I should be, and is this
Dr.
still
Restrepo,
just some immune manifestation of drug-induced vasculitis, crazy lupus? After we've dug everywhere and we're just going to call it that, and at some point in time, we're going to give this woman, cyclophosphamide and large doses of steroids, and she's just going to come back, and levitate off the bed again. I don't know. Is this GPA or drug-induced ankylosing vasculitis? Doesn't seem it, at least from all of these things. And so I'm left with a non-specific multi-system inflammatory disorder that I'm failing to let's just say articulately put my thumb on.
Dr. Restrepo, I'm going to try helping everyone understand what's happening here because there's so much of information going on by summarizing the case. If anyone else wants to try in the chat, please go ahead and do it. So there's this 59 years old female with a past medical history of Sjogren, and then who came in with sudden loss of vision. And she also has asthma from childhood and started on hydroxychloroquine recently. Apart from that, she's been on multiple medications, and she has a slight temperature of 102, and she's desaturating at 84% in room air and tachycardic. She's got lymphadenopathy, and CT abdomen showed also hepatomegaly as well as abdominal lymphadenopathy. And she's got pancytopenia, if I'm not mistaken. Her hemoglobin is 9 and WBC is 7 and platelets are 122. And apart from that, UA's got some amount of hematuria and granular cast consistent of acute tubular necrosis. And so these were the most important features with the lab so far. And apart from that, the biopsies, the lymph nodes showed interfollicular plasmacytosis. And that was something which I thought was important. And so as of now, this is the problem representation which I have for her. Does that change anything for you? Are you able to prioritize anything from all the differentials which we have discussed so far, Dr. Restrepo?
I gotta say, this is there's a ton of data here, and that she just has sort of a global inflammatory process that I like I said, I'm sort of struggling to better classify. It seems to have a predilection for, it seems to be resulting in a thrombotic microangiopathy, and it seems to have a predilection for the reticuloendothelial system by way of as well as the lungs, by way of the hepatomegaly, organomegaly, the adenopathy that she's having, and all these things. So I do think the neurologic and the ophthalmic symptoms are from the TMA. So, I think it's worth something we're going to have to act on the sooner side, maybe plasmapheresis, maybe like large doses of immunosuppressants in this time.
Awesome. Amazing discussion so far. And to just highlight, there are a few guesses in the chat which so far. One is there's a drug-induced lupus, and then there are a couple of others saying IgG4 probably, and then Castleman's disease, and there's an option of also renal scleroderma crisis. And Zach, did you want to reveal the diagnosis?
Amazing. And I think once or twice Dr. Restrepo did mention earlier,
Yeah.
and I see Austin nailed it in the chat. Final diagnosis was idiopathic multicentric Castleman's disease, the NOS subtype, with an autoimmune overlap. The IL-6 and VEGF were checked and were both very high, and the IL-6 was over the upper limit of detection. So the patient had mixed features of the plasma cell subtype and the TFRO variant. And then the TFRO stands for thrombocytopenia, anasarca, reticular fibrosis, renal dysfunction, and organomegaly. And the patient was given tocilizumab and had resolution of symptoms. I see Dr. Jeffrey Chen is on the chat. Maybe you'd like to say a few words how it was like taking care of this patient. Very, very complex case. And he has some very nice teaching points for us as well.
Hey Zach, thank you so much. You did such an amazing job going through this case, and again, also thank you so much, Dr. Restrepo. I learned a great deal just from listening from you going through each aliquot, and we were very similar to you, very confused. This is such a challenging case for us, and we had all the same diagnoses. Some of us thought maybe this was lupus, maybe this was lymphoma. And this is one of the cases where we have everybody involved. ID's on board, hematology's on board, renal's on board, rheumatology's on board. So we had the luxury of having many, many different teams thinking about this. So thank you so much for Zach for sharing the slides. Let me go to the next with the teaching points. So multicentric Castleman disease can be sometimes it can be easier to diagnose if you get a lymph node biopsy right away. It shows it. But sometimes it can be very complicated, especially it's complicated when you already have an autoimmune disorder diagnosed, like Sjogren's. Because the problem is there's a disconnect sometimes with the pathologist and with what you're giving them. So if the pathologist is getting the lymph node biopsy, they're looking at the chart and they're getting a sense of, okay, this is like lupus, Sjogren's, some type of autoimmune thing. They're going to be maybe a little bit biased and seeing findings that could be consistent with that on a lymph node biopsy or a bone marrow biopsy, they may be more hesitant to give a stronger diagnosis. So when should multicentric Castleman's be suspected? It should be suspected when you have a disease that looks like a rheumatologic disease. You're being told it's rheumatologic, like Sjogren's, lupus, ANCA vasculitis, but they have these three in combination: high fever and B symptoms, diffuse lymphadenopathy and splenomegaly, and cytopenias. So, one of the earlier things that I wanted to that was a very interesting discussion was could ANCA vasculitis cause diffuse lymphadenopathy? It's very interesting, and we don't know why. But even though ANCA vasculitis and other vasculitis cause significant inflammation, they very, very rarely cause diffuse lymphadenopathy. So that's one teaching point that I really learned myself while going through rheumatology training and learning these patients. And I wanted to share that secret with you guys. So if you see the combination of these two, so positive serologies, being told it's a rheumatologic disease, but you have all these three symptoms. And why do I use these three symptoms? Because if you didn't have the rheumatologic serologies and you have a chronic patient with high fever, B symptoms, diffuse lymphadenopathy, and cytopenias, you're automatically going to be thinking about cancer, lymphoma, leukemia, right? You're not going to necessarily be thinking about lupus or Sjogren's until now you saw the positive ANA. Now your mind is going to be maybe a little bit biased. But there's very little rheumatologic diseases that can cause this picture. So, and Dr. Restrepo really highlighted almost basically all of them. So lupus, Sjogren's, including drug-induced forms, macrophage activation syndrome, which is usually secondary to those things. He even mentioned sarcoidosis, which is a very, very rare cause, which is incredible to hear that because sarcoidosis is one of the diagnoses that I that I love, and it's my clinical passion. So very rarely you'll see sarcoidosis causes autoinflammatory disorders. But the big ones from a hematologic malignancy standpoint to cause rheumatologic serologies and also present this ways are lymphomas, usually it's diffuse large B cell, leukemias, and finally Castleman's. For whatever reason, Castleman's has a very high rate of causing positive rheumatologic serology. So ANAs, double-stranded DNA, any of the ANAs, ANCAs, IgG4, even granulomas, all of those can be caused by Castleman's, making it very difficult to differentiate if you're not looking for it. So it has to be an excisional biopsy of the lymph node. The reason is because without the excisional biopsy, you can't see the characteristic distortions of architecture. There's a couple different ones, but the big one is regression of germinal centers. So fancy way of saying that parts of the lymph node look smaller or bigger, and they're very characteristic of Castleman's. So earlier when you got the FNA, which is really good actually, surprisingly for detecting some cancers that will cause mediastinal hilar lymphadenopathy, the one that it doesn't catch is Castleman's. Uh, Destruction, if you have the lymph node destroyed by so much plasma cells, you don't have architecture. So you can't diagnose, you can't easily diagnose Castleman's either. So in this case, we had that. That made the diagnosis very challenging and why we got so many different biopsies before we really understood what was going on. The interesting point is, as far as we know, IL-6 is nonspecific and can be high in many diseases, but when it's extremely high, especially when the VEGF is high, that is actually a good biomarker for multicentric Castleman's, as far as we know. And the good correlate for this is the C-reactive protein, which Dr. Restrepo mentioned was a very interesting, unique finding in this case. And then finally, I'm going to comment a little bit, but this specific retinopathy is due to small, basically TMA in the ocular vessels, and that's why she had bilateral vision loss. So it can mimic GCA, but it's not going to respond to steroids, at least not quickly. It takes multiple weeks before it gets better. And the other thing is almost always bilateral, whereas giant cell arteritis is often unilateral in presentation. So the final teaching point is there's this syndrome called Tafro syndrome, which is very, very, very rare syndrome. But if you are able to recognize it, it will help you clue you in to multicentric Castleman's disease. So it's a combination of thrombocytopenia, anemia, reticular fibrosis on bone marrow biopsy, renal dysfunction, and organomegaly. When you have these things together, that's a key syndrome to make you think, could this be from multicentric Castleman's? Overall, this is a very, very complicated case, and thank you so much for presenting it, Zach, and Dr. Restrepo for doing all you do to explain each aliquot so well and eloquently, even though that this is a very rare, complicated case. Thanks so much, guys.
Thanks a lot, Jeff, for sharing the case with us. And thanks a lot, Dr. Restrepo, for this amazing hour of teaching and learning. And is there any two teaching points which you would like us to take away from the whole hour of discussion? Apart from the fact not to use hydrolysine.
Yeah, just to blame hydrolysine. No, this is you just peel back the layers of this case with every aliquot and just get more and more complicated. Obviously, I think it's important. One of the things that I'm usually a stickler about is if you're thinking about something that is affecting, kind of causing generalized adenopathy, and you have not succeeded non-invasively with non-invasive diagnostics. I think it highlights the importance of getting a whole lymph node in the actual evaluation of these processes, just because lymph node architecture is so crucial to subtype lymphomas, but also to get better picture of these sort of multi-system disorders that do have a predilection for the reticuloendothelial system, like we talked about. So things like lymphoma, sarcoid, all of the granulomatous infections, but also Castleman's. And I think I probably locked in a little too much to the HHV8, recalling that there's HHV8 associated and the non-HHV8 associated subtypes of Castleman. But that's most of what I got. This was an incredibly difficult case, and you guys had me squirming the whole time. So
We're
I'm
going to
never
make
coming
up
back,
by.
and
No, I was just
I'm
going to
never
say we're going to
doing these
make up
again.
by giving you a very easy case the next time.
That's what they always say.
No, for sure. Thanks a lot, Dr. Restrepo, and thanks everyone for being an amazing participant in the chat. And I hope you guys had the rest of a amazing day, rest of the day and the week as well. Until next time, bye.
Thanks, everyone.
Yeah.